Pulmonary fibrosis is a disease in which tissue deep in your lungs becomes thick and stiff or scarred over time. The formation of scar tissue is called fibrosis. As the lung tissue thickens, your lungs can't properly move oxygen into your bloodstream. As a result, your brain and other organs don't get the oxygen they need. Sometimes doctors can find out what's causing fibrosis, but in most cases they can't find a cause. They call these cases Idiopathic Pulmonary Fibrosis, more commonly known as IPF. IPF is a serious disease that usually affects middle-aged and older adults. IPF varies from person to person. In some people, fibrosis happens quickly. In others, the process is much slower. In some people, the disease stays the same for years. IPF has no cure yet. Many people live only about 3 to 5 years after diagnosis. The most common cause of death related to IPF is respiratory failure. Other causes of death include pulmonary hypertension, heart failure, pulmonary embolism, pneumonia, and lung cancer. Genetics may play a role in causing IPF. If more than one member of your family has it, the disease is called familial IPF. In this programme, we hear the expert views of Roland Dubois, Professor of Respiratory Medicine at Imperial College of London, who discusses the challenges faced in managing IPF and his hopes for the newer approaches emerging to manage the disease. We also hear from Joseph McCall, who gives a first-hand account of living with and managing IPF.
Idiopathic pulmonary fibrosis, or IPF, is a chronic disease of the lung in which the lung becomes progressively scarred over time. It's different from chronic diseases that people are more familiar with, like asthma or COPD, where the brunt of their disease is in the bronchial tubes, which deliver air to the air sacs of the lungs. And it's in the air sacs that oxygen is taken from the lung into the bloodstream and carbon dioxide is removed from the lung. It's the air sacs that over time become relentlessly, progressively and incrementally scarred, and the scarring process continues over time. The disease commonly affects individuals in their middle to older age groups, and it's a little bit more common in men than women, but the end product is the same. Individuals notice that they're becoming more breathless doing their day-to-day activities, and then less than their day-to-day activities, ultimately becoming housebound, carer dependent, and they feel completely helpless, hopeless, useless, and eventually they will die from this most appalling of chronic progressive lung disorders. IPF can affect individuals largely in their middle to older age groups, although younger people can be affected by this disease process, particularly when there's a familial history of this disease. In other words, it's occurred in more than one member of a family, and likely therefore due to be some genetic predisposition. It doesn't spare class or ethnicity, and globally the disease appears to have the same sort of incidence and prevalence rates. Making the diagnosis of IPF can be tricky, and the main reason it's tricky is that general practitioners or primary care physicians often presume that most middle-aged people who are breathless either have asthma or COPD, and they treat them with therapies which of course have no impact upon IPF. So it's crucial to have a high index of suspicion. There are 3 areas in which one can be stimulated to think of a disease that's not an airway disease. The first is wheeze. If a patient wheezes, and they'll notice that themselves, it's more likely they have an airway problem than IPF. Secondly, if the GP listens to the back of the chests of these individuals, they hear these fine crackling noises, and that is not present in airway disease. And lastly, a very common tool is the peak flow meter. It's an instrument that allows a very quick recording to be made of the rate of airflow out of a patient's lungs, and that is normal in IPF, but obviously not in a disease that affects the airways. And it's absolutely vital to make this diagnosis early, because the worse the disease is, the less likely one is going to be able to do anything that will improve the patient's quality of life. And the reason for this is that most of our approaches to therapy at best slow down the disease process and don't reverse it. So if you're massively breathless when you first see a doctor, the best you're going to stay is massively breathless. So it's really important to have a high index of suspicion and make this diagnosis as quickly as possible and refer to a specialist. I think there are a number of challenges to the management of the disease of patients who suffer from IPF. And the first we've talked a little bit about is getting the diagnosis early and making GPs and the patients themselves, in fact, aware that not every middle-aged breathless person has asthma or cigarette-induced COPD. And parenthetically, most people who get IPF have been smokers, thereby giving rise to the increased risk of getting the diagnosis wrong at the beginning. I think the next phase is to be sure that the patient is referred to a lung specialist and perhaps in some instances to a lung fibrosis specialist so they can have access to the best diagnostic methodologies to make sure the diagnosis is right. Thereafter, there are treatments that can slow down the progression of disease. But let me be clear, there is no cure and there's nothing yet that we have that will really improve lung function short of lung transplantation. And of course, there's a real pressure on organs, and many patients who would benefit from a lung transplant never get near a transplant centre for a variety of reasons. And then the final things which are often overlooked are issues of quality of life, making sure oxygenation is maximised, and there are devices that patients can use at home to help oxygenation. Rehabilitation. The fitter they are, the better they are, but there are few units around the country that can offer a properly controlled program for this. And I think finally, and again often overlooked, is counselling, talking to individuals, explaining what the problem is, and when end of life occurs, treating them with dignity, compassion, and easing the end of life burdens. A final word for the carers. They suffer almost as much as the individuals, and the individuals with this disease often worry more about their family than themselves. And it's awful disease to watch. I can't tell you how awful it is to watch a patient progressing and then dying from this fibrotic lung disease. So one should not underestimate the support that family members and loved ones need.
When I was first diagnosed with IPF, because it was a disease that I'd never heard of, I wasn't too particularly bothered in the first instance. It was only when I went to see the consultant, when he explained to me the severity of the disease and the possible effects on life expectancy, that I became rather shocked and a little bit bewildered by it. My symptoms started because when I was speaking to people, I was finding that in mid-sentence I had to stop and I started to cough. And that was for many weeks. I probably should have gone to see my GP, but I didn't. It was only when I was speaking to someone who asked me, had I been working in a dusty environment, that made me think that there's possibly something wrong and I should go and see my GP, which I did, and it was then that I was diagnosed with IPF. It's vitally important that people who have the symptoms that I had, that they see the GP very quickly indeed, because I probably left it too long. It's a disease that can be controlled, and they really should see a GP as quickly as possible, because it can only get worse without them seeing him. IPF has affected me because I can no longer participate in activities that I used to be able to do. I can no longer play sport. I can no longer go on holidays where we used to go walking because of breathlessness. Even helping my wife with the shopping, anything heavy becomes a major problem because I become short of breath. And so, generally speaking, most of the activities that I used to do, I can no longer participate in. If you've recently been diagnosed with IPF, I would say to you to continue to do the things that you always did. Be positive, get the help of the support groups that are available, but remain positive and continue. It's essential you try and continue to do the things that you always did.
It's very difficult to be precise about how common IPF is because there have not been any comprehensive epidemiological studies. But just to give you a sense of this, roughly 15,000 people will have IPF in the United Kingdom at any one time. 5,000 individuals will develop IPF during the course of a year, and about 5,000 will die from IPF. That's more people than die from many common blood cancers, many other cancers in the United Kingdom. So while it's a relatively rare disease, 15,000 is quite a large number, and then you amplify that across Europe, and suddenly you have approaching 300,000, 400,000, 500,000 people with this disease in Europe alone. The causes of IPF are sadly not clearly identified at this point, and it's likely that individuals who are going to get IPF have some form of genetic predisposition that affects especially the lining cells of their air sacs, as I said earlier, the areas where oxygen exchange occurs. So with this background of a genetic predisposition, a number of triggers, likely inhaled triggers, interact on this genetic platform to drive the recurrent injury that results in the lung fibrosis. The sorts of things that can trigger it are cigarette smoking. We know for sure that if you're a cigarette smoker, that increases your risk of getting this disease. But there could be other inhaled pollutative, for example, factors that can trigger the disease process, and maybe also some infective agents, especially viruses, could play a role. But as I said at the beginning, we don't know precisely what causes this disease, and therefore we can't cure it. We can't remove the cause at this point in time, meaning that the best we can do is to slow down the rate of progress once the disease has been identified. Idiopathic pulmonary fibrosis, or IPF, is, as I've said, a chronic progressive scarring lung disease, and people often presume from that there is absolutely no hope for them. We would like to leave a more hopeful message. Firstly, if an individual gets to specialist care early, then that means that they will have a much better outcome and a much better prognosis than if they present with very late disease, which by definition is severe. And secondly, there are newer approaches to managing this disease that are emerging that we believe will not only slow down the disease process, but may well in the fullness of time arrest it completely. If an individual has a moderate lifestyle and not too disturbed breathlessness, then it's great to be able to stop the disease process while they're still able to have a reasonable quality of life than if you stop that disease process when they're severely affected and bedbound. So we do have hope for the future, and we would wish patients with IPF to believe that their case and their cause is not utterly without hope.